Good afternoon. A cause search for residual dizziness in patients treated with repositioning maneuvers at our center. We begin our first slide with posterior cupulolithiasis or the graviceptive heavy cupula shown in red in this slide. The Half-Hallpike test in posterior cupulolithiasis is not the gold standard. Why? Because of the variations in the anatomy of cupula. In neutral posterior cupula, the plane of which is in line with the Earth's vertical during the Half-Hallpike testing does not get stimulated and therefore no positional nystagmus is elicited. The second variation is a canal angulated cupula which during the Half-Hallpike testing results in inhibitory ampulopetal deflection generating downbeating contratorsional positional nystagmus. The third is a vestibulum angulated cupula which during the Half-Hallpike testing results in excitatory ampulofugal deflection generating upbeating ipsitorsional positional nystagmus. So ideally the cupulolithiasis should be evaluated by half-Hallpike positioning which often elicits a prolonged upbeating ipsitorsional nystagmus. This is the left Half-Hallpike position shown in this picture where from the upright sitting the head is positioned around 120 degrees at the free end of the examination table. However, because it is not appropriate to evaluate the cupulolithiasis from upright sitting, the supine positioning is done in such a manner that head is positioned just 60 degrees making half-Hallpike position. If at the head end a pillow of around 4 inch thickness is placed, there is no need to support with hands as is shown in this picture. Inversion test in posterior cupulolithiasis, why it is important? This is a half-Hallpike position to the right shown with this diagram as the nose down to the left is done. A positive inversion test means when the right torsional upbeating nystagmus, the right half-Hallpike position becomes left torsional in nose down to the left, and this is suggestive of adherent type of cupulolithiasis. A negative inversion test is one where the right torsional upbeating nystagmus in right half-Hallpike position disappears, and this is suggestive of non-adherent type of cupulolithiasis or a dynamic heavy cupula, which in the recent types has been attributed to a new variant called short arm posterior semicircular canalolithiasis. With this, we begin our first case, 31-year-old male with 4 days history of positional vertigo. CNS examination is normal. The most of the neurological examination except for the positional testing is normal. The half-Hallpike test to the right elicits after a latency of around 4 seconds a prolonged upbeating right torsional nystagmus which lasted for around 2 minutes. At 2 minutes, the inversion test, that is the nose down to the left, was done to look for the inversion test positivity or negativity. On nose down to the left, the right torsional upbeating nystagmus reverses polarity and becomes left torsional and downbeating as is shown here, and this inversion nystagmus lasted for around 1 minute. This is a positive inversion test, and how it occurs and what is its importance we will come to know as we proceed through the slides. The mechanism of inversion test during the half-Hallpike position is explained by the evolved third law for the vertical semicircular canal. During the half-Hallpike position to the right, there is a excitatory ampulofugal cupular deflection, and the excitatory projections from the right posterior semicircular canal are to the right superior oblique and left inferior rectus, generating a slow phase VOR which is left torsional and downbeating. The fast phase VOR is therefore a positional nystagmus seen as right torsional and upbeating as we had seen in the previous video. As the nose down to the left is done, there is an inhibitory ampulopetal cupular deflection, and the inhibitory projections from the right posterior semicircular canal are to the right inferior oblique and left superior rectus, generating a slow phase VOR which is right torsional and upbeating. The fast phase VOR, which is a positional nystagmus or an inversion nystagmus, is therefore left torsional and downbeating as we had seen during the inversion during the previous slide. The second case is a 39-year-old female with history of positional vertigo. The CNS examination is normal. Neuro-Otological examination except for the positional testing was normal. The right Half-Hallpike test was done. From long sitting, she is positioned to the right Half-Hallpike position, and we see a upbeating right torsional nystagmus. So it was decided to do a therapeutic Epley Maneuver hand in hand. The right Half-Hallpike position was maintained for around 1 minute, after which the head was inclined 90 degrees to the opposite left side, which was again maintained for 1 minute, after which lateral recumbent to the left was done with nose down. This is the position 3 of the Epley, and this was maintained for around 1 minute, after which the patient was uprighted, completing one Epley Maneuver. After 1 hour, a verifying right Half-Hallpike test was done, and this shows a right beating horizontal nystagmus, implying that canal switch to the right horizontal semicircular canal has occurred, and this has to be evaluated with the supine roll test or the head yaw test. From the long sitting, the patient is positioned to the supine neutral position, and you can see a left beating horizontal nystagmus. This is a lying down nystagmus, a sign of secondary lateralizing importance in the horizontal canal BPPV, which beats towards the non-involved or the normal side in cases of the geotropic variant. The lateral head roll to the right was done after 1 minute, which elicits a geotropic nystagmus with quick component beating towards the lowermost right ear, and lateral head roll to the left also elicits a geotropic nystagmus with quick component beating towards the lowermost right ear. So this patient was treated with the Epley Maneuver. From short sitting, she is positioned to the non-involved left side, maintained in this position for around 1 minute, after which the nose down to the left was done like this, and this second position was maintained for 2 minutes, after which the patient was uprighted to short sitting, completing one Epley Maneuver. Next day, patient returns with residual dizziness, especially on getting up from supine position. The right Half-Hallpike test did not elicit any nystagmus, and patient did not complain of any vertigo, but the main complaint was getting up from supine dizziness. So the oculomotor patterns were noted on getting up from the supine position, and this elicited a upbeating right torsional nystagmus. So this is a paradox. The type of nystagmus, that is the right beating and upbeating and right torsional, which is expected in the right Half-Hallpike position, is seen in getting her up from the right Half-Hallpike position. So this patient was elicited with the right Half-Hallpike testing, which after a latency of 10 seconds elicits a upbeating nystagmus of prolonged duration. And let us see what happens during the inversion test. As the nose down to the left was done at 1 minute and 47 seconds, the upbeating right torsional nystagmus disappears. There is no nystagmus or nose down to the left. So this is a negative inversion test. How it is explained? This is right Half-Hallpike position, and the short arm posterior canalolithiasis, as the patient is taken up from the right Half-Hallpike position or else positioned to the Half-Hallpike position, the otoconial debris falls on the posterior cupula, making it heavy. This is a dynamic heavy cupula with negative inversion test. Had it been a cupulolithiasis of adherent type, the nose down test would have been positive, as we had seen in the first case. So why inversion test is negative during the Half-Hallpike maneuver in short arm posterior semicircular canalolithiasis explained here. This is the sitting position. This is the Half-Hallpike position, causing excitatory amplifical cupular deflection, leading to upbeating right torsional nystagmus of prolonged duration. As the nose down to the left is done, the otoconia fall away and there is no cupular deflection, and the nystagmus which was present disappears. So, human experience with the canalith repositioning maneuver. This is a landmark paper by the eminent Professor John Epley in 2001. He said that if persistent nystagmus is maximizing in one provocative position but does not occur in the inverse position, it suggests that cupulolithiasis may be present due to non-adherent particles falling away from cupula in one of the positions. But in that case, the diagnosis is less certain. Around 20 years later, Scocco published this paper called Sitting Up Vertigo as an Expression of Posterior Semicircular Heavy Cupula and Posterior Semicircular Short Arm Canalolithiasis, and this explained how this happens. So now with this, we have certain new variants of posterior semicircular canal BPPV. The three variants are short arm posterior semicircular canalolithiasis. Second is periampular posterior semicircular canalolithiasis, which is often associated with a constriction around the periampular region of the posterior semicircular canal. And the third is posterior heavy cupula. The three conditions often coexist in one permutation or more combinations. Setting up vertigo, a entity first described by Bela Bucchi in year 2011. In her series, 20% of classic BPPV, 43% had subjective vertigo. Symptoms were lateralized coming up from the one disc Half-Hallpike position but not from the other disc Half-Hallpike position, and there was a posteriorgraphic evidence of truncal oscillations in some patients. So posterior semicircular BPPV subtypes are 5 posterior long ampullary arm semicircular canalolithiasis, the garden variety. The second is posterior non-ampullary semicircular canalolithiasis, one with downbeat nystagmus during the disc Half-Hallpike testing. The third is posterior semicircular heavy cupula with inversion test positivity. The fourth is short-arm posterior semicircular canalolithiasis where the inversion test is negative. The fifth is periampullary canal side posterior semicircular canalolithiasis with often associated with a constriction in the periampular portion of the posterior semicircular canal. So the residual dizziness, 3 important reasons: canal switch in 6%, otoconia in posterior canal at more than one location, and posterior cupulolithiasis. Retesting, that is the verifying position test at 1 hour and 24 hours, are essential to look for elimination or a change in the pattern of nystagmus, which may be because of canal switch. Posterior cupulolithiasis best evaluated by Half-Hallpike positioning and positional nystagmus inversion test. Thank you.